And we're live.
All right, good morning. It's Thursday, February 20th, and this is Senate Health and Welfare. We are listening to testimony this morning on our committee bill, and I think we're getting close to a time as a committee when we can start putting language in place, and we'll talk about that a little bit if we have time later, probably more likely tomorrow. So we'll also be spending time on this bill tomorrow with experts from Millbank Memorial Fund and also document again. So that'll be great. All right. So this morning we have Brendan Krause. Why don't you come up? And did you two want to be coming up together?
Yes, please.
Another chair. Should we introduce ourselves? Yes. Okay. So, Senator Hart, when he gets up.
Yeah, sure. Senator Larry Hart, Orange County. Senator Sanders from Orleans County.
Ginny Lyons, Chittenden Southeast.
Martina Rock, Chittenden Central.
And Cummings, right here, Washington. So thank you for being available, coming in. So you could introduce yourselves for the record and then we'll listen.
Thank you, Madam Chair. Thank you for having us. My name is Brendan Krause. I'm the Director of Healthcare Reform at the Agency of Human Services.
For the record, I'm Will Dempsey. I am the Health Data Officer for the Agency of Human Services.
And we have a third colleague on the phone, Alicia Cooper, who leads payment reform at the Department of Vermont Health Access.
Okay, thank you.
Thank you for the opportunity to come in and testify and to have this conversation. I'm going to start off just with some high-level comments, and then we'll take the bill outlined by sections. And my colleagues, who are smarter than I am, will be taking the lead on some of those sections, particularly the healthcare data and the payment reform. So just at a high level, I'd like to say, that we're excited about the opportunity to bring the threats of healthcare reform together. We think that the bill is directionally consistent with, where we're going and where we've been. And so excited to talk to this committee about, the way you see these pieces fitting together and how we can support in our current and future work. So specifically, I think that some of the things that the bill is particularly good about is describing the collaboration across the state entities and the organizations that would be involved, specifically the Green Mountain Care Board and the Agency of Human Services. And I think there's an opportunity to highlight the strengths of those organizations in the various sections, and as we just begin to discuss, how the work will get done. More specifically, the AHS and its broad health system reform oversight, including community-based providers, mental health and substance use, et cetera, and then of course the Green Mountain Care Board's regulatory and hospital budget and health plan review process. So starting with the statewide healthcare delivery plan, section 1. AHS would recommend some greater clarity around the development of the statewide healthcare delivery plan. And in particular, we would propose that potentially sections of the plan that correspond with the regulatory rules are more clear in terms of the various entities, namely that GMCB authors related sections to hospitals and regulatory oversight, and AHS covers sections that are more specific to other healthcare providers and community-based providers, and also that acknowledges and considers the role of the Department of Financial Regulation, or DFR. And AHS also believes that a statewide healthcare delivery plan should not be solely focused on hospitals, but again, include those other community-based providers, as I'm sure.
And we've heard that from others, so this is really helpful.
And we would appreciate learning more about the hospital strategic plans and how the community views them as different or consistent with hospital improvement plans in Part 4. As you know, AHS is currently working with hospitals to develop transformation plans in response to all of our appointments 167 report. And we just like to get further clarity or have further discussion about how those plans differ or are similar to or intertwine with intermingle with the those transformation plans that are already underway. Moving on to section 2, in terms of the health system evaluation to support improvement and development of statewide healthcare delivery plans. Again, AHS would recommend greater clarity on how GMCB and AHS would jointly establish an advisory committee, and how we would jointly leverage it. And then a bit more clarity about how the committee would be established and what its purpose would be and how we might articulate that a bit more clearly. So we're doing that endeavor. And at this point, I'm going to hand over to my colleague, Health Data Officer Will Dempsey to through the integration of clinical and cost.
Can we talk about parts 1 and 2 first?
Of course.
And then we'll go on to part 3, because you said a lot in there. So the questions, I'm not going to start at the end with advisory, but just thinking about the things that you said in terms of having clear regulatory roles for AHS or DFR or Fremantle Care Board for building the plan. How do you see the process going from your perspective? How would the plan be built more or less, and who would bring people together? What are you thinking there?
I mean, we're open to discussion on that point, but obviously, I think that it would make sense again to look specifically at the roles and the sort of strengths of the individual organizations, and probably in terms of convening and leading transformation work in the space of non-hospital based providers that would largely, I think, fit nicely with AHS's mission and similarly.
So I'm thinking, so you've indicated some community-based services like our mental health services and so on being engaged with this. And the bill or the framework currently has hospitals putting together strategic plans and having plans for their services, service delivery. Would you be thinking of having community-based services similarly have plans, or how does that sort out?
I guess I would look at sort of health service areas and regions, and as those hospitals are creating those specific plans and as there are efforts made to move care out of hospitals into the community or provide some of the services that are currently lacking and preventing hospitals from doing things like being able to discharge patients that don't have places to go or don't have appropriate community-based treatment options. That's when the larger system being brought into.
So, right. So, I mean, we think about Act 167 that's going on, and you're working very hard with hospital transformation and looking at community-based services. And then we will also want to ensure that, well, you write a plan, we do this plan over here, this plan happens over there. How do we provide the leadership to put those things together?
Yeah, and I wouldn't say they're completely separate. We should,
or is it
organic? Yeah, no, I think that we collaborate across the way, along the way. But have individual focus in terms of. I guess it depends on what we're trying to fix, in which scenario. And so I think there are certain parts of hospital transformation in particular that have probably greater alignment with regulatory functions. And then those that have more to do with strategic planning functions that are a little bit closer to the work that's already going on at AHS, different those things.
So bringing those two together is important.
I think so.
Yeah.
I guess this is the second time we've heard from hospitals some concern about most of them volunteer boards, lay boards, to get them overwhelmed in this planning process because they're doing transformation. To try and do 2 plans at once is probably more than you can expect of a local board. So I think we need
So
to be
relying
clear into sequencing and how they mesh.
Yeah, the sequencing and the meshing is the piece that I'm kind of look at. And so the work that you're doing with 167 obviously is key to having hospital, regional and local services sort of together.
What did, I wasn't here last year. What are the goals of the transformation plan? And then how are those different from the goals of the strategic plan?
Right. So,
Which I think just we need to think through.
so, right, it's in you do have a copy of the report online for that, but I'm going to ask Brendan, if you don't mind talking a little bit about what you are doing with the transformation process, because I think that'll help answer Senator Cummings.
Sure. Most immediately, we're dealing with the urgency of the situation in terms of cost and access. And so we are, this week we had typical assistance call with 4 different hospitals. So we are and plenty of others. So we have contracted with, we are leading an effort that includes a contracted support to provide some of that boots on the ground that you described, sort of the lack of capacity the hospitals have to, open their books and look at service lines and look at sort of where their financial struggles are and how they could provide access differently and how they could collaborate with their partner hospitals in their regions or otherwise to align not just on service delivery, but also back office function and administration and that sort of thing. So that's the immediate step that we're taking now. There will be 14 different hospital transformation plans that will develop over the next 6, 12, 18 months, dealing with the crisis source. But the way I'm thinking about what you described, the Senator, in terms of the strategic plan, is there's also been a lot of discussion about, okay, yes, we need to deal with the immediate crisis, but where are we going? Like 2 to 3 years from now, we can't wait 2 to 3 years to take action, but it could be that the strategic plan answers that question and starts to think more holistically about, for those not dealing with the immediate crisis, where they're going to go.
Is there a timeline that you could suggest, that you might suggest, that would sort of move us along so that when 167 happens and then the next step happens? Because I know one of the concerns that you've expressed previously is access to transportation, getting people from one spot to the next, or other social determinants. I know housing is in there, it's all mixed in together, but if is there a timeline that we could put in so that, transformation already has its goal, and then how would then we begin to mesh together the next step and the next step? So thinking about dates for achieving our goals.
It seems like there's a normal flow, the way you described it.
Yes.
The current crisis, to make sure you've got access at all, and then keeping your hospitals afloat. And then once you settle that, you move into, okay, now at least some solid ground under us financially. How do we move this process forward? It should flow.
So that's an ask. I mean, if you wouldn't mind thinking of that, and what dates you would put on, and what's the destination. So that we don't want to, I agree, we can't put a huge burden on volunteer boards, no question about it. But we also need to get to where we need to get to. And then thinking about Elliot Fisher's comments about having a learning plan that, we learn this and then it moves on to the next step and continues. Yeah.
We'll take it away. Absolutely.
Thank you. And then in terms of DFR being included, can you talk about that a little bit?
I just think it's important to clarify and include the various regulatory roles that each of the organizations have, and obviously the Green Mountain Care Board, and I'm not going to speak for them because I don't know in detail as much as they do. So in terms of rate review, particularly as we face unsustainable premium increases in our insurance, that this is all sort of part of one system, and so we can't just look at hospitals, we can't just look at payers, we can't just look at community-based providers. And so I think those three organizations are the ones that have the most oversight or leverage in those spaces. So that's sort of the extent of my thinking, but I think in terms of their regulatory function, both with plans.
You know, we have to ask them, you know, what role do they see for themselves in this? And maybe it's minimal and maybe it's more.
Well, they certainly have a strong role in, you know, financial oversight of the health, of the health plan, of health payers. And since that's a burning platform for us right now, I think it's important to keep it on the table.
And then the other question is, at what stage do the community services become more engaged? So how do we include Vermont Care Partners, for example, and others in this? They have a huge role, right? And so the continuity of care becomes critical. Okay. Senator Goulart.
Just a question, just because I can, and because I'm still confused on all of this, but do we have a plan in the short term to staunch the bleed of the current situation? I know that this is more of a sort of interim and long-term solution, but I still am unclear as to what the short-term plan is. And I know we talked about it last week when we had our larger group meeting. But any thoughts from anyone on that?
I will defer some of those comments to my Green Mountain Care colleagues who are working on this every day. I would say that the short-term plan is that we're working now with hospitals, and hospitals have been very responsive to our care transformation efforts. And so we're literally, you know, staffing them with, you know, project managers and financial analysts and experts in care that have a redesign, particularly with a rural focus. So that's the immediate short-term plan, which is to just continue that work and develop over the next months, not years, solutions, which will grow into larger transformation plans. But, you know, the next 6 months will be very intense for it.
Right, we don't want to make it more intense than it has to be.
Yeah.
We get it. Okay. Thank you. Any other questions? So, and after we finish this, it would be really helpful to have your comments in writing and stuff like that. Great. And any further thoughts you have about leadership with this, timeline, specific dates, goals within the planning process. So that's important.
I have a question.
Sure.
If you guys do create a advisory committee for this, where would these people come from?
I think that would be something we would discuss, obviously, with the committee and also with our colleagues. I think it would be important to have members from all significant sectors, so not just clinicians, but also, you know, people who have business acumen in the area. And also, you know, it'd be interesting to get some views from out of state, to the extent to which that's of interest. So, to learn how, you know, or we can do that work ourselves and bring it to the committee. But I think it would be good to have a broad consensus of opinions and gain consensus on actions.
Yeah.
And roughly how many members?
That I sort of defer. I would ask sort of back to the committee. Well, it depends, I think, on the purpose of.
So this is a good question, and because we've asked, you know, why do we need the advisory committee right now? So that's why do we need it right at this point, or is it something that needs to be developed as the plan comes out? Right? And I'll just say one other thing, but Pennsylvania has a model for this, and I think it was brought to us by Elliot Fisher.
Right. So, I mean, I can tell you my opinion, just in terms of committees, you know, less than 10, 5 to 7. Again, with, I think, expertise both from the business side of healthcare, as well as the clinical side, as well as the patient side. So, I didn't think of a number
Community
of
services.
exactly,
Yeah, it's just-
exactly.
Be huge.
Right. So, but I would encourage, you know, you can have a committee and you can still engage those other stakeholders. So my opinion would be that you get some people around the table to start problem solving, as Elliot Fisher described at the beginning um, when we were-
Yeah, so I think the committee's gonna have to decide how this fits at this point. I don't know what your opinion is about it.
Yes, I mean, it's something we've been considering for a long time, and have kind of gone back and forth because some of the feedback we get is, oh, that's just more bureaucracy, that's just one more group. And so I think it's important that we not duplicate or sort of add noise where it's not helpful, but I think it's also useful to get a group together that can sort of take that higher level view who aren't in the trenches every day thinking about the next immediate crisis. So I think there's value.
So are we ready to move on to part 3? All right.
Take it away, Will.
Well, your last name.
For the record, Will Dempsey, DEMPSEY.
S-E-Y, okay.
SEY, Health Data Officer for the Agency of Human Services.
While he's getting ready, I would just like to acknowledge that we're also excited about the direction of increased linkage of clinical and claims data and the potential power that gives to understand not just what's happening and how it happens and how expensive it is, but what the result is.
First one to say that.
Whoops.
Everyone else.
That's good. Oh, there's a difference.
I come from the data world, so
Yeah.
I have a difference.
Go ahead, Will.
Thank you very much, Chair Lyons. Good morning, senators. So I just have a few slides. I want to describe a concept called the Unified Health Data Space. Some of you are probably familiar with this when I talked about this briefly the last time that I came in and testified. But given what was in part 3, I thought before I make any recommendations and we get into the bullets, this might provide some context around what AHS's position is, the work that we are currently doing in this space, and the work that we want to pursue in the future. And we view this as very much a continuation of ongoing work. And we're pleased with the directionality in the document for this section as well. So I did make sure to double check that every acronym is defined and applied.
Thank you.
And I provided a copy to the committee, I think it was last night. So I'm going to talk a little bit about the Unified Health Data Space and another project called the Medicaid Data Warehouse and Analytics Solution called MDWAS. I'm going to say MDWAS, UHDS, just because those are very, we like long acronyms. So MDWAS is a Medicaid project that started about 2 years ago in the Agency of Human Services. That's building a data lake, a data warehouse, and a data analytics and reporting solution. And I'll get into more detail and explain all that, what that means. But essentially, this is building a foundation for the Agency of Human Services for the Unified Health Data Space, utilizing federal dollars to pay for the vast majority of it. Yes, that's suddenly become
We've already cashed the check, right?
we are cashing checks currently. Is what I would phrase that, Senator. Yes. So the good news is MDWAS is slated to go live this calendar year and be done and go into maintenance and operations, which is a tremendous success. I want to highlight the project is on schedule and on scope and on budget, which is phenomenal for such a large project. The team has done a phenomenal job. I recently became a sponsor of this project, so I'm learning more about it, but I stand on the shoulders of giants that came before me, who did a lot of work over many years to set us up for success. So this MDWAS UHDS concept builds a unified repository for comprehensive health data analytics. So part of this is it will attribute your record to you using what's called the Master Person Index, sometimes referred to as the Master Patient Index, although that's an evolving language. Moving away from the word master to main is a common term. It's evolving. So data comes in on the left-hand side of the screen through the data sources. Current data sources for MDWAS are the Medicaid Management Information System, MMIS. That's an AHS-owned system to manage Medicaid in Vermont. You have the Vermont Health Information Exchange. That's the clinical data that Vital operates as a legislatively designated operator of the Beehive. I want to highlight that's for the Medicaid population at the moment. So Vital receives a file from the state saying here are the Medicaid members. Vital performs matching and provides the clinical data for the Medicaid members to our vendor for MDWAS, which is Deloitte. The program Money Follows the Person contributes data, as well as the Pharmacy Benefits Management System for Medicaid. So those are all contributing data to the data lake today. The data lake went live in November of last year. The data warehouse is in development right now. That will go live in July. And the data analytics and reporting solution will go live in November, which is tremendously exciting. It's a very large project with a phenomenally fantastic project team doing great work. I want to highlight in the bottom left, see future data sources. This is what I'm going to talk about with the directionality of the points in part 3. We have social determinants of health. That language is also evolving, moving towards social drivers of health, as well as another term that gets mixed in with that, which is health-related social needs. Commercial claims, which is what's in the outline, as well as patient-generated data, things like that. So all our ideal architectures, all of that data flows into the data lake. The data lake is essentially like a landing pad, a runway. It's a front door. So the data comes in, it does some minor checks to make sure that things are on the up and up, who's contributing data, who's supposed to be contributing data, and it's really a staging area. That then pushes the data over to the data warehouse. And this is where the data validation checks occur. So it's making sure that things are structured appropriately, things are not structured appropriately, and structuring them. And it functions as essentially our single source of truth for the data, and builds what we refer to as a longitudinal record. So I'll use myself as an example. So all of my data that's related to me is attributed to me, so that at a personal level, so that way providers are able to see the whole me, not just bits and pieces of me. Then finally, the end result is the data analytics and reporting, which allows for reports, visualizations, dashboards. The tool that's being used is Tableau, if folks are familiar with that. It will help the state meet our state and federal reporting requirements, as well as the last bit, which is empowering users to create custom ad hoc reports. So allowing analysts, and not just analysts, to build these. Our ideal future state is providers would have access and views based on role-based access control to be able to see their patient population. We could partner with the community service organizations, so that way they could work with their population. We could work with payers to work with their population. Again, all this within state and federal law, using role-based access control. I don't want to scare anybody.
Security.
High security, for sure. But allowing the data that can be shared to be shared and make it in a usable format. So it's not just a massive text file or CSV as a common transmission where it's just essentially an Excel spreadsheet. This will enable dynamic usage of the data and understanding of it. So before I move to the next slide, I've talked a lot and used some technical jargon. I want to pause and see if anyone has questions. Caroline? So I want to touch on the unified health data space and give just some context in textual form. This is all in accordance with the HIE strategic plan that was approved by the Green Mountain Care Board. It's on our public facing website. I included a link here. I know if you print the document, that doesn't really help. My apologies. Next time I'll include it as a footer. But in that strategic plan, we talk about the work that Medicaid is doing. And Medicaid is the leading edge of linking clinical and claims data in Vermont. And by the end of this calendar year, we will have that ability to demonstrate the usability of that, of linking clinical and claims data. We had a lot of conversations in the HIE steering committee, which helps draft the HIE strategic plan that goes to Green Mountain Care Board. And that Care Board also does have a non-voting membership today on that steering committee. And through our consultations with the various organizations that participate, we decided we want to utilize MDWAS as a proof of concept, show value using federal dollars. So that way it's at that time a pretty safe funding source. And then the next step would be to scale that. And I want to talk about what scaling means, because it would be in two different ways. It would be scaling beyond the Medicaid population. Right now, it's just the Medicaid population. So we refer to it as general population, more people.
Sounds like DOC.
And then in addition to more people, we would like to expand, and this touches on points that are in the outline. We would like to expand the scope of the data that's being included. So more people, more data. We're talking about clinical and claims data, but even beyond that, social determinants of health, health-related social needs, Part 2 data, patient-generated data, even healthcare workforce data, because this system will allow us to do analytics that we've never been able to do before. So any questions on that before I go to my last slide?
It's really exciting.
What's HIE?
Oh, okay, Health Information Exchange. Did I miss one? I did. It's in the link. Thank you.
Go ahead, Steve.
Good answer. So, Sam's okay. That's where Senator Major, all this Sam's. So it seems like what you're talking about here is a lot of what the committee bill outline already seems to be covering. So it seems like you're doing a lot of what is already in here.
Yes.
And maybe part of this might not be necessary. I do think there are definitely some things in this in part 3 that I didn't hear you talk about at all. But it does sound like you are looking to do a lot of what this is gonna put in statute.
Or it's in flight in some way, shape, or form.
Yeah.
And we can discuss more granular details as this evolves into a committee bill for sure.
Yeah, well, this has a lot of emphasis on Vital. Can you talk a little bit about if Vital's been involved in any of the planning you're talking about?
Yes, that's actually my last slide. Came prepared.
Are they?
So Vital is our key partner. I manage Vital's contract and negotiate the contract with the Agency of Human Services. Vital and I, the CEO of Vital and I meet daily, essentially, and Vital staff and my staff meet every single day, if not multiple times a day. What our recommendation is to remove the specific references to Vital within the linking clinical and claims data and make it the Agency of Human Services and focusing on the work that the Agency of Human Services does to give us maximum flexibility. Vital is a key partner in all of the work that we do in this space. They collect the clinical data and store it and match it and then provide it to us being the unified health data space in this concept, not me specifically. Without them, we wouldn't be able to have the clinical data. So I did speak with Beth Anderson a little bit about this yesterday, and it's our feedback is specific to the linking clinical and claims data. Vital has a very important role when it comes to collecting data and managing data and attributing data, especially clinical data.
I'm going to ask a question after you go through your
Okay.
second. Right?
And I'll go through the second one,
Yeah.
which is just adding some specifics around health-related social needs and social drivers, determinants of health. Those are very important concepts to the Agency of Human Services, as well as around the country and around the world. And so including them in this scope and the data that we are driving to collect would be very helpful.
Okay. So then the question is, do we need the language or not? We'll be discussing it, but certainly when you have something going on as significant as this, we might want to reference it in the statute so we know what's going on. So that's one of the things we might consider. The other is how we, and one of the goals in that section is to improve interoperability between and among hospitals and providers. So, and what you are talking about right now is Medicaid specific. So then to expand that to private insurance and others. So there's a greater pool of clinical data. So that's the other goal in the sort of framework in the bill itself. So I don't know how to think about that, or how you might think about that from your perspective. How can you help us with that?
Yes. So I think I'm happy to speak to it if you'd like, Caroline.
Sure, yes, please.
So a lot of this concept of the unified health data space has been around for a few years in the Agency of Human Services, and we've been working on building the infrastructure components of which the Vermont Health Information Exchange is a key component.
Absolutely.
Key component. This will not work without the Vermont Health Information Exchange. This is taking that data and combining it and enriching it with additional data sources and making it so that way it's that longitudinal health record. So it's not even just the clinical data about Will Dempsey. It's what are my claims looking like? What are my SDOH screenings looking like? Things like that.
So, but the risk pool that you're looking at with all of that data is Medicaid
Today.
today. So then the goal is to expand it. And then how will you and AHS work to improve, or how would you work with, I mean, one of the pieces in here, it doesn't happen right away. Obviously, it's not first. I think some of it might be going on right now with hospitals, and that is interoperability, hospitals working together and sharing data. And do you have a role in that, I guess is what I'm asking.
Absolutely.
Okay, so
And through the VHI.
through the VHI, yes.
For sure.
So, yeah, so it seems essential in some way for us to have, an eye on that, if you will, oversight. And the way we do oversight is through legislative initiatives.
Wow, I'm still trying to reconcile yours. You're talking claims data. I assume that's VCures.
Right.
Yesterday, both Blue Cross and the Health Advocate testified that they didn't see where it was very helpful. It wasn't very accurate. It told you I filled the prescription. It didn't tell you if I ever took it. And Blue Cross was concerned about to integrate it would take a great deal of time and money. And I'm really hesitant to drop another expense on the Blue Cross at this point in time. So how do we reconcile?
So my understanding, Blue Cross wouldn't have an expense on their end for this vision.
Okay.
I'll start there.
Would they have to put any significant amount of time? Because time is money.
Time is money. I agree, Senator. No, they would not, because this would be us working with the Green Mountain Care Board to get data that they have in hand, not going to Blue Cross Blue Shield to get data that they have. So it would be within the state.
Any other questions for Will on this? Thank you. A lot there. And we didn't have it when I looked first, your slides. So can we get your slides?
Oh, my apologies.
Send it, keep me, that's all.
Yeah, I will follow up with our legislative liaison and make sure they keep it.
Okay, so the big question then, right now, the bill is putting Vital in charge of all of this. And you're putting yourselves in charge of all of this. And so what conversation, and HIE, obviously, steering committee is key.
Yes.
So, we need to resolve that issue.
Vital is a private organization, right? It's not.
501c3 with a board that consists of insurance and others.
So this is state organization. I think that's where we have more control. Vital at some point could be bought out, be replaced, could be merged. I think it might be better to
Stability.
have it in-house.
And you're willing to take it on. Well, the other thought
They're
that,
contracting out.
yeah, we do have Vital coming in on Tuesday, I think, next.
Mike Smith's person.
I know. Nolan,
For the record, no language fiscal, if I might make a suggestion, one suggestion would be you allow them decide whether they want to contract with Vital or do it themselves.
UHS no option.
we can put that in as an option. That's a better way to do
Give them the
it. And
authority,
we,
power.
yeah,
May I?
Yes, please.
And this would be specific to linking clinical and the linking of the clinical and claims data and the scaling of the unified health data space. Vital's contract with the Agency of Human Services is for the Vermont Health Information Exchange.
Got it.
And there's no intention on the part of AHS to change that dynamic. So I'll say that very out loud, so we're all very clear. We do not want to change the dynamic with Vital. We support them and encourage them and collaborate with them very closely. And they do great work. And we want to continue that great work.
Very thorough. Thank you. Thank you, Nolan.
And our final comments relate to section 4, hospital budgets and payment reform. And for that, I'm joined by my colleague, Alicia Cooper, who directs payment reform at the Department of Vermont Health Tax.
Good morning, everyone. For the record, Alicia Cooper, Director of Managed Care Operations for the Department of Vermont Health Access. Regarding section 4, AHS is supportive of the potential to align payment models across public and commercial payers using tools like reference-based pricing and global hospital budgets. Generally, in this section, we would recommend additional clarity in the resulting bill language around AHS's and DVHA's authority to set Medicaid rates and to implement payment methodologies such as global hospital budgets per our 1115 Global Commitment to Health waiver. My additional comments are based on some of DVHA's and AHS's experience with these specific approaches. And I'm about to mention a bunch of things. I recognize that we're short on time today. And so if any of these would be interest areas for a follow-up conversation, we'd be very happy to come back and provide more information.
So I think what would be very helpful is to have your testimony in writing.
Mm-hmm.
And then we'll try to find some time for you to come back and to go through that with us.
Okay.
That would be helpful. Okay.
Would you prefer me to not share any additional comments at this point and to share it in writing so that we can move on?
It might be a good idea. Can you give us generally what you're thinking briefly? Can you do that?
Sure. Regarding reference-based pricing, we just wanted to share that the Vermont Medicaid program has been benchmarking our Medicaid reimbursement against Medicare across a variety of services and providers for over a decade. This has given us a consistent reference point against which to benchmark Medicaid rates and has enabled us to ensure consistency in reimbursement across different providers who are participating in Vermont Medicaid's network. We have maintained this underlying structure of reference-based pricing tools, even as we've implemented broader-based payment reforms, including our transition to fixed payments through our Vermont Medicaid Next Generation ACO program. And we expect that we will continue to maintain these structures and would welcome being named as a stakeholder to provide input as the Green Mountain Care Board would implement similar structures for commercial payers. And then regarding global hospital budgets, although Vermont Medicaid is not presently implementing global budgets, AHS and DVHA see the potential of these models to contain system costs while giving providers revenue predictability and incentivizing population health. DVHA has been implementing fixed prospective payments to hospitals through our Vermont Medicaid Next Generation ACO program since 2017. And in 2024, we began a complementary pilot program called the Global Payment Program, such that hospitals participating in both would begin to receive fixed monthly payments for the vast majority of their Medicaid revenue. And these have been implemented together as an incremental step toward hospital global budgets for Medicaid. Consistent with the AHEAD model participation requirements, DVHA is working to develop Medicaid hospital global budget methodologies, and we see this as a successor model to the fixed payments that we are currently using through our ACO program. And so those are sort of the high level points, and I'd be happy to provide that additional detail in writing.
Thank you. That's very helpful. And we're going to need to see your information in writing. That would be great if we could get that. And then we'll try to have it. We'll try to find a chunk of time where you could come in and share it with us. We will be moving into the conversation on payment reform and economics next week a little bit more, or starting tomorrow, actually. So when you come back, we may have fresher minds for thinking about it. Great. Thank you.
Thank you.
Thank you. Great. Good. Quick question from Leslie. Oh, okay.
I seem to remember, Devin, I think it was mentioning, mentioning that a lot of the hospitals are already looking into implementing, reference-based pricing or others.
So what we're gonna do is we're gonna hold that question until we get to reference-based pricing next week. I know it's a good question and you can ask that question.
Well, no, I'm asking a question of you, and so I would like to hear like a more, if my memory is serving right, I kind of want to hear more of a comprehensive outline of what they're doing.
We'll get there.
Yeah.
Do we have the reference-based pricing bill in here?
We've got a lot of those in here.
You have, okay, because I don't have any after.
So yes, that was kind of a discussion that is a preview of what's to come. We've got to go through that, and we will. We're going to begin with it tomorrow, and then we can have folks in we need to, and then next week we're going to continue with it. Chair Foster.
Good morning.
Good morning.
My name is Alan Foster. I'm the chair of the Green Mountain Care Board. Thank you, Chair Lyons and the committee for having me today. I'll proceed along the same path that Director Krause and Mr. Dempsey that works for the committee. So first, part one, the statewide healthcare delivery plan. The Green Mountain Care Board is very supportive of this. We think this is imperative for the state to understand how the systems are working across the entire spectrum of healthcare delivery and payments. I agree with Director Krause that DFR should be a participant in creating the integrated statewide healthcare delivery plan. Briefly, just a little bit of background, simply likely understands, the care board is focused on hospital budgets, but we do not review independent provider budgets, long-term care, mental health, and VAs. None of that was in our purview. And we've been focusing on trying to bring that information to the fore for the last couple of years because we think it's imperative that those community providers remain solvent in part of our system. We think that this bill, the outline of this bill, would promote that. So as of today, I can, within 20 minutes, give you the financials of every single hospital, at least the high level, most important indicators. I don't know that anybody can do that across the system. So this would allow us to do that. I think it's imperative. So I would recommend that you add DFR if they're amenable to working with the agency and the care board. There was a question about like the urgent plan, and I appreciate that question because we are very concerned that things are moving very fast. Some hospitals are making changes, the insurance companies having serious problems. I think first and foremost, we need to get an inventory of the financial picture of a number of providers, EAs, FQHCs, hospitals, and have an understanding of where everybody is and what the risks are to the system. It's been in the press that Memorial, the FQHC is having financial difficulty, very serious financial difficulties. That was honestly news to me as of 2 or 3 months ago. And I don't think that really helps create a good system of care. So I think that we have to have an inventory of where everybody is financially and what the prognosis looks like. Similarly, I think that people out of Gavin where Blue Cross was as of even 3 months ago or 6 months ago. So having us all work together, I think would really be helpful. In terms of what the transformation would look like, I want to recognize that there's a tension between creating really good process and doing the work, right? You have a large advisory committee setting it up, stakeholders, meetings, planning, charters. You're going to set something up and have to use things while you're doing that. So we need to be cognizant of that. There's one line in here that I did want to flag just for people to think about. So directs the Green Mountain Care Board to review and approve hospital strategic plans for alignment with the statewide healthcare delivery plan.
we'd want to think about what that means and what happens if the care board rejects the hospital strategic plan. How does that relate to hospital budgets? And we need to flesh that out with the committee a little bit.
That, I think that was kind of where we were getting to when Brennan was talking as well. What does that mean? And the hospitals are very concerned about having a strategic plan and another plan and this plan. So I think we're all very understanding of that, trying to figure out how to make it 167
Right.
plan work together.
And then the last bullet on that section requires AHS to monitor other states' agencies for alignment with the statewide healthcare delivery plan. I wasn't really clear on exactly what that meant. Of course, the care board is entirely independent. We don't work for the executive or the administration. So if the administration is having oversight over the care board and our decisions, that's a little bit different. We need to think about if that's what we're intending here, if that's desirable.
John's here, I'm afraid. Oh, you shouldn't be fearful.
We're all very careful.
Yes, you should.
You're in charge.
Well, I kind of wanted to answer this question, but I can't answer it, so I'm curious what it does to you.
In this draft language, it's a little vague.
Yeah.
Monitor, I'm not sure what monitor means. And other state agencies, that's gonna be a number of people, so it wasn't clear.
We need to flush that out.
Yeah,
Okay.
I'm supportive of the independence of the care board. I think removing the politics is wise.
Yeah.
So I would recommend it. To the extent we're monitored or have to report, we do it to the legislature and the public, as opposed to having potential political oversight.
Well, I don't,
Go ahead.
you'd have to, clue me in here, but were you envisioning AHS and monitor, like counting through my care board as a state agency? Is that, they're not a state, agency, so I don't think.
But transportation,
Well, technically, we are a state agency, but we're meant
you're a
to
regulatory
be, we're
board.
independent regulatory.
Yeah.
So this wasn't intended to cover for care. Yeah,
Okay, appreciate that. Thank you.
No, so that can be, I'm trying to sort out, I think we're hearing a lot of needs here for how to integrate and bring people together and make it work, and who's taking leadership on what, and how's it all gonna fit together? And that goes back to the timeline, so putting a timeline in for specific types of goals, so any help you could give us on that be useful.
Yeah, I think that, so Director Kraus and I and Deputy Commissioner Brown, Emily Brown, have been speaking the last couple of weeks.
Oh, good.
And I hope we'll have more to share with the committee in the near future about.
So let us know how you'd like to do that, because I was going to bring Emily Brown in, but if we can avoid the step of having each of you in separately another time, and we could get some uniform agreement on language, that would be really helpful.
I think we can work on that.
Thank you. Thank you.
In terms of the affordability crisis in the state is real, and I think it's nowhere more pronounced actually in healthcare, right? Single digit tax increases do not compare to the tax that we're seeing in healthcare. And that's really what it is, essentially tax on our businesses and our people. And that really challenges our state goals of affordability, property tax relief, education support, right? Because education going up so much, the healthcare costs, and economic growth demographics, right? Healthcare costs do not help economic growth or demographics. So I would suggest that in our work in thinking about transformation plan, whether it be urgent or long term, we actually work backwards. So I really appreciate it. I think it's the section 4, the total cost of care section.
Okay.
We need to get our spending in line with national norms. We're already way above and we're going faster. We need to at least abate the growth and get more in line. So this is a very important section. And what this says to me, the total cost of care section, is we have a pie of money. How much more can we afford? And work backwards from there. We can't keep spending more and more and more and then wonder why we have an affordability crisis in healthcare. We have to see how much we have and then say, whatever the national growth is that we accept, that's how much we have now allocated.
We tried to do that. Bills, CPI, or I don't know what the national Nobody was listening then, but now people are listening.
Right. I think the urgency has been recognized and people are ready to roll the sleeves a little bit. So what does that mean? I think one, we should look and ask the question, can we pay more? Can we get more from Medicare? If we can, let's get more from Medicare. Can you raise, what's that?
Don't leave it on the table.
Yeah. Second, do you want to raise Medicaid rates? Do you want to raise taxes to support increased Medicaid payments? Do the insurers have the ability to pay more and people to pay more on the commercial side? I would argue very strongly that they do not. And I would question whether or not additional taxes are appropriate at this time either. So then you have to look at, here's how much we have if we can't pay more. What can we maintain with that? What will be lost? What do we have to have in our communities so that we have care? And we have to make hard decisions and prioritize things. We also need to look at what I'll call waste or operational inefficiency. And that's what the care board has been focused on the last couple of years. Can we eke out every ounce of efficiency and productivity and waste that we possibly can? And with the hospitals, we've been working on that. There's more to do for sure. But that's not going to solve the problem. There's no like magic flip the switch and waste is gone, we're there. It's a bigger, deeper transformation. So part of the plan, I think, has to consider what we must have and how do we prioritize what we need in each communities. The 167 work in the Oliver Wyman report was a giant first step in that effort, right? It's really a roadmap that AHS and the care board, the hospitals can work off of to move forward. So I think we're at that moment when we're making those decisions and going.
I guess, may I?
Yes.
It was great having the medical researcher / data auditor who was here.
Nancy Kane.
Nancy Kane, thank you.
Yeah.
And one of the things that she really was trying to drive home, I think, is that, we have a lot of, we kind of know what we need to do to a certain extent, and we need to do it, so we need to have the political will to make the hard decisions. And so as much as possible from you and from AHS and all the experts, it would be great to hear, instead of trying to sort of dance around and problem, just like, say it, say what needs to be done. And that would be helpful to me anyway, as someone in this committee.
Yeah, I'm happy to. And I think the care board has been doing to the extent it can at a reasonable pace what needs to be done. I mean, we've seen a lot of uproar is the right word, but like when we make hard decisions, it's difficult and we're doing it. So we've really decreased the commercial rate increases to hospitals. That needs to be done. And we've been doing it. We enforced an $80 million budget overage on UVM Medical Center. That takes a political will. We did it. And it's a difficult decision and it does cause pain where you do it. It's not easy to deal with these things, but that's what has to be done.
But it needs to be done in the right way so that services aren't cut, sacrificing services for lowering costs in a way that is planned. And we've talked about that.
I'm not sure.
Well, no,
It's like cutting schools. Maybe one of the things we can't afford is
yes.
absolute convenience for absolutely every service.
Yeah, yes, Senator, you're right.
Today's, so how do you maybe we can't afford obstetrics in every hospital. So how do you set up a system so that
How do you plan for that?
people can be transported to the service when they need it and when maybe they get a birthing center locally?
Got it.
That to me is what a plan is. It's not how do we provide everything we've always had in the same number of buildings, in the same number of locations, when everything costs more and we aren't getting new younger workers in to pay that.
So let me explain my comment, because what I was thinking is the cut to services that we saw as a result of a request to lower the budget was a cut of services without being integrated into a plan and without consideration for consequences. So the concern here is we need to have that broader perspective so that when change is made, when transformation is made, then we know it might feel uncomfortable, but we're covering the folks who absolutely need it in a way that needs to be done. So it is not simple. And Senator Douglas, you have a question.
I was just gonna make a comment to the coming said that I like what you're saying. It's very pragmatic. But I'll be a devil's advocate here. I'm a little rascal like that.
Okay. I'm an old debater.
No, I'll push it back. I'm just making a comment of if we're trying to attract new people to the state and then younger people, I worry that if we're having bare bones services in some hospitals, that might be a deterrent. So, I think there's balance.
We've got that same thing with
Yeah.
schools. People won't come if there isn't a small local school in your community. But we also know that people won't come if they can't, because we do community ratings. So if you're 22, you can get cheap health. Yeah, cheap healthcare. So, in other states. So how do we balance that?
And maybe while also providing other incentives to people, while removing incentives, adding other incentives to the areas, which is other committees and ombudsman.
Yes.
I don't want to ignore the witness we have at the end of the table.
Oh, you're still here. Oh, fine.
Senator Gulick, you have a quick question?
It's a quick comment, which is that we're seeing it in education too. Transportation is going to be a key to all of this. And I know we talked about it, but it's going to be.
So I just would comment I agree with the perspectives. You need to make sure you have that. Now, I do think that you should think about beyond just like hospital walls. Is there a better way to deliver it? If the hospital is removing primary care, is that detrimental to attracting people or serving people's health needs in the community? Well, no, if there's like an alternative there that the FHC or whatever it might be. So, my family has frequent health needs and you need it. You absolutely need it. So I think the tension, this is what we're talking about, is the plan so that this all works together and you don't lose services in your communities, especially rural ones where it's harder. And I think, in terms of, this is a great conversation. So the UVM reductions, from their own perspective of doing their work that they need to do, they determined that was the right decision for them in that moment. But as a system, it doesn't work well and it's not consistent with population health. And that's where we need to go, is moving from the isolated, siloed, potentially correct decisions to how does it work as a system. That's really the point of your argument.
You've just used the phrase population health, and I know that that's an interest of ours as well. So is there a place that we should be including that in our?
I did have a recommendation for part one, which I think is really important, and it sort of hit me more recently. We can have any reform, transformation, payment, reference-based pricing, whatever you want to do. It won't make a difference if it's not trickling down to the hospital boards and to the compensation of the leadership. You have to align their incentives with your state incentives. So if you look at some of the ways that executive compensation is structured, a big component of it in some places would be margin. That's how much money they make on the operations, which is a necessary thing to have positive margins. But you have to consider, is that with really high expenses? Is that with really high commercial growth? Because if you're getting a bonus on really high commercial growth, that's not where we're at as a state. So I would recommend that we do ensure alignment with more on the ground with the operational level, and that executive compensation should align with state goals.
And what are the state goals that you would consider?
I think I would refer just to 18 VSA 9371, our principles of healthcare reform. That's what we're trying to do. And we want to make sure that that's pulling through to the management board levels.
And is population health in there? And again, I don't know, but I think that's also that's been a significant goal. Yeah. So thank you.
Exactly.
That's all. Go ahead.
So, I think I hear what you're saying. There's a lot of legalese in there, but I think what I'm here trying to prove for you is, as you're saying consent, are you talking about like a rolling scale for executive payment? If the hospital does well financially, then the executive does well financially. And also, and maybe you can answer this for me. There's been a lot of hubbub in the media about the executive paid salaries and bonuses at UVM or whatnot. Is that hospital-wide, statewide? Is that an issue everywhere? Because I've only heard about that at UVM, and as far as I'm aware, you know, like North Country isn't having any executives.
It varies fairly dramatically across the state. So, you know, the network is really large, it's a $3 billion enterprise. So the people who would populate the executive management have different experiences and skill sets, and you know, they're doing a different job, I think, than that's not to like minimize the important work that an executive's doing at a small hospital, but it is a different workload and management level. So you do see much larger executive compensation at UVM than you would say Springfield or Grace College, right? Smaller hospitals, different operations. All I'm saying is that I believe we want to make sure that executive compensation aligns with state goals, and our state goals being reducing commercial costs. And whether the hospital does well financially or not, we want them to do well financially, but we don't want it to be done well financially at the cost to ensure solvency or people's ability to afford healthcare. Right. We want it to be done on operational excellence, population health, moving patients out of hospitals. We want hospitals to do well financially without care being all done in hospitals. You see the tension, growing revenue and growing margin can increase commercial costs and increase healthcare costs for it's done in hospitals. I mean, we actually want the opposite a little bit.
We actually have that in here somewhere. We have reduced that. Any reductions should go toward reducing commercial premiums. But what you're saying is broader and probably more effective.
I would say both. I'm just saying that you should align executive compensation with state healthcare goals.
Yeah.
I think you can do that by referencing that principles of healthcare reform that's in our statute. And then in terms of the line, I forget where it is now, about any reduction needs to reduce commercial prices.
Yeah, it's in there.
So I agree with the sentiment very much. From a practical implementation standpoint, I have questions about
How do you do that?
so let's say, look, clear ones in my head. UVM cut dialysis, or it's planning to. Maybe it won't happen actually, but that's where it is currently. Does that reduce costs? Well, sure, because they lose $4 million or $6 million a year on that service. So now that's not having to be shifted. So yes, but it hurts population health, and maybe it goes somewhere else. So how do you judge? Right, or the reduction of Mad River primary care, does that actually reduce costs?
Mm-hmm.
It depends. Are those patients now going to a more expensive setting?
Mm-hmm.
Then they're not. So like analyzing all that gets very, very complex.
And you're leading me into the question about quality data analysis, quality metric patient analysis and health improvement through my favorite thing. So, and I know that the ACO has a very good sort of system for evaluating quality. And where do we put that, and how do we put that? And that's a question I should have asked AHS, but I'm also asking you. It's in here, but I know that evaluating what good is there in the ACO structure and what can we salvage from that will help us do exactly what you're talking about.
That's a really good question. And quality, awareness of quality at the statewide level, the regulatory level, AHS, others, is a gap. We need to improve our understanding of quality in the state. I was looking at some data last night, this morning, and we are seeing signs that quality is not where it was 3 years ago. And quality is a very broad spectrum, but we are seeing signs of concerns. Increased Medicare fines for quality, some star rating changes from Medicare. So we do need to invest in that, improvement that. It should be part of the regulatory process.
Yes.
That is in our charge and mission. We have no staff dedicated to it. Our hospital systems finance team is 3 people, and we don't have a quality person or team to do any of that work. But it should be part of our decisions. And it's actually part of the Oliver Wyman report too.
Yeah.
Is looking at whether or not there's sufficient volumes to hit quality standards and necessary volume.
So I guess the ask here is for both. How do we put it? It's in the bill, but how do we improve that language? It's not something that you can say, go do it, but it is something we can say, how do we do it? And what I'm also hearing you say is that there are resources needed in order to accomplish this. And there might be resources for other things.
There is. So I think quality should be part of our budgeting process.
Okay.
I mean, it is, but I don't think it's at the level we think is appropriate for this moment. And then we need greater transparency statewide on quality. Right. So BPQHC has a lot of quality information. We may be connecting some of these things and bringing some transparency would be beneficial to the state.
BPQHC.
Right.
Yeah, I know they're doing great on that work. It's good.
But the issue I'm saying is it's unconnected from us in our regulation, and there are, you have to speak with them more about what they can share publicly and what kind of information they can bring in a detailed way.
That's a good question. And we did have them in. We had, I always forget.
Hillary,
Yeah, we had Hillary Wolfing in, so
she's really been helpful.
very much so. Okay. What else do we need here?
I believe it's Stephen Andrews might be here to speak to if you're ready to move on. You can
Yes.
speak to the actual.
We've got 6 minutes.
Oh, okay.
Right. And we can also reschedule should that be necessary.
So why don't we have him speak to the integration of clinical cost data? That's,
Okay.
and I believe Dr. Merman might be available for tomorrow morning.
Yes, so we can continue that conversation with him.
Yeah, and I'll come too. That's
Okay, good. Yeah, please.
So let me turn to Stephen if that's okay. Stephen, are you here?
Yes.
I am.
Oh, there you go.
For the record, Stephen Andrews, Director of Health Systems Data and Analytics at the Green Mountain Care Board. A couple of thoughts about where we're trying to head with the integration of clinical data and payer data. In general, we're supportive of the idea. We're worried about some of the details of how we get there. We started having discussions with Brendan Krause and Will Dempsey and others to see what might need to be done to make this happen. A couple of things that I would mention. In general, data that are siloed are less useful than data that are integrated. I think we can all sort of agree on that. There are concerns though when you combine data, and I think one of those concerns is patient privacy. I think you'll hear from other people questions about what happens if we put all of the data into one place and make it available. I don't think that's a technical question. That's one that's much more about what is the political will to put public health concerns over privacy concerns for individuals. That's a discussion we had somewhere else other than the data team. We also are worried that the payers will push back if we try and make the data combined. I think they're worried about sensitive financial information getting out, and they don't want to have a competitive disadvantage. That's something we'll want to address and make sure that they're comfortable with before we proceed. We also have concerns that the Medicare data has some strict rules in our data use agreement about whether or not we can share identifiers. Identifiers are the pieces of information like your name, your address, social security that allow you to link the data with other data sets. We'd want to make sure that they would be comfortable because you can't link the data without those identifiers, and we don't want them pulling the data. We need to be able to have the data to do the work that we do. I also want to mention that we do support what AHS was saying about putting a state agency in charge of the effort to lead the combination of these data sources rather than a vendor. We're a little concerned vendors come and go. It feels more comfortable for us to be working with a state agency rather than a vendor that that's not really a partner of ours, so we would support that as well. I'd also like to ask my Deputy Director, Lindsay Kill, to add any other comments she has, because she works much more closely with the data than do I. I'm a little bit more distant. Thank you.
Is that it?
Lindsay.
Hi, good morning. For the record, my name is Lindsay Kill. I'm the Deputy Director of Data and Analytics at the Green Mountain Care Board. I would just like to echo everything that Steve already mentioned. I think you hit everything, Steve. The only thing that I will add is about the lag between the claims in our APCD and potentially the ability to get claims directly from submitters for this effort to be more responsive and timely. Currently, we have a lag of kind of do the math on the fly. We currently don't have all of 2023 data, and we only have partial preliminary 2024 from the federal government for Medicare beneficiaries. So that's a lag of, going on a year now. So reading through the rest of your outline, I was really hearing a lot of themes around urgency and important policy making, decision making in real time, and just want to flag that potentially there are claim sources that would not have such a long lag.
Lindsay.
Thank you, Lindsay.
Steven's done here. Steven, did you want to add anything else at the end here?
No, I think I covered the main points that I wanted to be able to cover. Thank you.
Okay, great. Thank you so much. And Owen, do you want to wrap up, or is there anything else you'd like to add?
The only point I'd add on that is, I would want to hear from the insurers on the integration. We have a risk of losing an insurer and a risk of another insurer not wanting to participate in Vermont. So anything that chills insurer interest in being here, I think should be understood.
Great. We'll make sure we check in. Thank you very much. Anything else from anyone before we wrap the day?